Our next speaker is Dr. Hossein Mohboubi. He is a board-certified neurotologist and skull-base surgeon at the House Clinic. He completed his residency at UC Irvine, followed by a clinical fellowship in otology and neurotology at the House Clinic and UCLA. Dr. Mohboubi has published extensively in national and international otolaryngology journals and has authored several book chapters in neurotology and neurosurgery textbooks. He is a member of the American Neurotology Society, and he is here to talk to us tonight about middle ear pathologies. Welcome.
Thank you so much for the kind introduction. It's a pleasure to be here today. Does everyone hear me okay? All right, very good. Okay, so I'm going to shift gears a little bit and talk about some middle ear pathologies that you guys are all familiar with. And as ear surgeons, as an audiologist, obviously, we always look at the middle tympanic membrane and deal with the middle ear and its issues. So we're just going to do a quick review of common things that we will encounter on a day-to-day basis, and we'll also touch upon some of the more kind of uncommon ones. I have no disclosures. So as we all know, hearing loss is very common. A lot of people have it, and we have different rehabilitation methods. These can vary from simple listening assistive devices, over-the-counter hearing aids, to more sophisticated hearing aid technologies, from simple behind-the-ear ones to completely in the canal ones. Then you have the option of implantable hearing devices, and obviously in certain cases you have the option of cochlear implantation. So oftentimes we are trying to either amplify sounds and improve hearing by bypassing the middle ear, or just by assisting either the conductive mechanism or the sensorineural hearing at the inner ear level with the different rehabilitation methods that we use. So it is essential to understand the anatomy and be aware of what can occur here, especially if you are seeing a patient, doing an evaluation for hearing tests or for hearing aid fitting. Sometimes we look in there and things don't look normal. So obviously it's important to know, what to expect, what to encounter, and the differential diagnosis. So the middle ear is bounded by the tympanic membrane laterally, and then the medially you have the inner ear structures, or the otic capsule, and you have the middle ear bones, malleus, incus, stapes. You have the facial nerve that passes in this area, and the eustachian tube opens into the middle ear. It helps drain it. And you have the skull base above it. You would call it tegmen. It's tegmen tympani when it's in the middle ear, and it's tegmen mastoideum when it's in the mastoid area. And the brain sits on top. And you have the carotid artery that passes next to the middle ear, and also the jugular bulb and the jugular vein. So a number of pathologies that affect these structures can essentially involve the middle ear, and it's important to always consider them when evaluating a patient and examining their ears. I will start the talk with a case presentation, and this was actually a real case, and we wrote it up as a case report, so that kind of gives it away that probably it's not like a typical case, but anyways. An 18-year-old female comes into clinic for a hearing test. They've had a 6-month history of right-sided hearing loss, ear fullness, and they hear an intermittent humming noise that's not really synchronous with their heartbeat. And there's nothing that makes it better or worse, and pretty healthy patient. And you look in there with your otoscope or with your microscope, and this is what you see. And you do an audiogram. It shows a mild conductive hearing loss, and the tympanogram is vibrating, but just a little bit less, so type AS. So just by looking at this, does it look normal? Does it look abnormal? It kind of looks like there's something purplish, pinkish at the bottom, right? So you guys, probably think of some possible options. Think about it, and then we'll kind of get back to this case at the end. So again, looking at something like this, it's good to know kind of what to expect. And obviously, as ear doctors, we can always chime in and do an evaluation, and we can decide together, whether proceeding with hearing aid fitting is the best option for this particular patient or not. So the most common condition we encounter in terms of pathologies that can involve the middle ear is the tympanic membrane perforation, probably the most common pathologies that you guys also see. And there could be various causes. Could be a result of trauma, whether it be accidental injury with Q-tips, from a car accident, from bear trauma, for example, during flights, if they have a sudden or accelerated descent. Could be a result of infection, which is very common, and also could be iatrogenic. Maybe the patient had a previous tympanostomy tube placed, or maybe somebody did a surgery on the eardrum and just didn't heal well. So when we are dealing with a tympanic membrane perforation, we always ask about acuity. If it just happened, they just poked the eardrum, we always tell patients that you have a good chance of spontaneous healing. I always tell them about 50-50 chance it might heal within 2 or 3 months, but usually if it hasn't healed by 3 months after the onset, then you know that, okay, this tympanic membrane perforation is not going to get any better. And depending on the size of it and location of it, we might use different language to communicate with each other, audiologists and ear doctors. Pinpoint perforations are usually a result of either infections, or if somebody has had, let's say, an intratympanic steroid injection, sometimes they don't heal. That's easily treatable. We can do in-office procedures such as paper patch laryngoplasty, and in certain cases, if that doesn't work, surgery. And obviously this would not result in a huge loss of hearing, but they can still cause a little bit of a conductive hearing loss, especially if they are in the posterior and superior quadrant. Then you can have marginal perforations, and it's usually defined by perforation that touches on the annulus. They can be central, which wouldn't touch the annulus. They can be near total, meaning when you look in there, you only see a very thin rim of tympanic membrane around or right around the malleus, and also they can be total perforations. Most often they will have conductive hearing loss, and it is usually worse in the low frequencies. Patients can complain of buzzing, ringing, tinnitus. They can have fullness, and if it's a result of infection, or if it results in an infection, they can also have ear drainage, either acutely or chronically. Workup pretty much essentially the same in many of these conditions. We would get an audiogram. We will see most likely an air bone gap, unless it's a really small pinpoint perforation that's anteriorly, kind of like with tympanostomy tubes. They don't always show a conductive hearing loss when you look at their audiograms. The tympanogram will most likely be a type B, and sometimes if you look at an eardrum and it looks like there's a perforation, but sometimes these are actually small retraction pockets, especially like where the eustachian tube is. And one key element to differentiate would be to look at the volume. If you see usually more than 1.5 ml, that's a high likelihood that this is an actual perforation and you're connected to the entire middle ear space and the mastoid space. But if the volume is not that high and it kind of maybe looks kind of a little funky, it might actually be just a retraction pocket and not a true perforation. In terms of treatment, patients have the option of tympanoplasty, and we always tell them the main reason would be to help prevent infections, and also to help them be able to get the ear wet. If they're swimmers, they like to get into water activity so they don't have to cover their ears. But depending on the cause and depending on how big the perforation is, how many surgeries they've had before, we always counsel them that, hey, your hearing may not get back to what it was before or become as good as your other side, and even after tympanoplasty, you might need to wear hearing aids. So not infrequently, actually, patients who are especially older and maybe they just have a little bit of hearing loss and that's all they care about, they say, okay, yeah, I'm okay with not doing a surgery, and we would refer them to audiology for fitting with hearing aid. And that can easily bypass or amplify sounds and then help with the conductive hearing loss that is caused. But if it's a clean ear, usually small, the tympanoplasty can certainly help with both improving hearing and minimizing chances of infections in the future. Otosclerosis, yes, questions?
Quick question.
Yes.
Is there any kind of perforation, like let's say a total perforation, that you can't do a tympanoplasty on?
we can do a tympanoplasty pretty much on any perforation. If it's a total perforation, or if somebody has had, let's say, 2 or 3 previous failures, or if it is a really narrow ear canal, we would do what is called a lateral graft tympanoplasty, and that's when we would go in and remove all the epithelial tissue from the eardrum. If there is a little rim of a fibrous layer, we would leave it be, and then we would remove the entire ear canal skin, and then put a new fascia in, put the skin back in, and essentially reconstruct the whole new eardrum. So that's pretty much the way to go for total perforations. For smaller ones, like this, if it's just like a 30%, 40% perforation, you can still do a lateral graft, and often some people might choose that depending on a number of factors. Let's say you have a 30% perforation, but the entire eardrum is just sclerotic. It's just like a big, rim of calcification. We know that's not going to have a good blood supply for a medial graft, and that is when you just go lift up the eardrum, put a fascia behind it, and try to repair it. But any perforation would be repairable, in essence. Yeah. Yes.
And one more question in regards to perforations and healing on their own. What is statistically that they will heal on its own, and when do you decide that they wait to see if it's going to heal on its own versus doing tympanoplasty?
Smaller perforations, like if they just poked it, I would say anything probably less than 50%. They usually have a chance of spontaneous healing. If you look at the literature, the data is, all over the place, but I would probably say about 50-60% chance it might heal within 3 months. So if someone comes to me, they just came out of the bathroom and then used the Q-tip, and then they sneezed, and then they poked their eardrum and ruptured it, and I saw them the next day, I tell them, come back in 3 months. If it hasn't healed, let's talk about options. Any other questions? Okay, very good. Next, we're going to talk about otosclerosis, probably the second common pathology encountered by all of us. It is indeed, at least in the United States, the most common cause of conductive hearing loss between ages of 15 and 50. In other parts of the world, infection and perforation is usually the most common cause. It is more prevalent among Caucasians, and then more in Asian population and African American population. There's a female preponderance in terms of its incidence, and also can be bilateral in a minority of cases. There's been a long debate about what causes otosclerosis, and a lot of data is from old research and literature, and the closest thing we found to an etiology was an elevated anti-measles immunoglobulin levels within the perilymph. This data is from probably like 50s, 60s, and 70s, when people were interested in studying otosclerosis at more depth. And there is actually a very nice diagram that shows that as MMR vaccination took off, over the mid 20th century, the number of otosclerosis cases kind of went down. We still don't know if there's a clear connection. Obviously, we see it in people who have been vaccinated, but talking to older associates in our practice, Drs. Brackman, Dr. House, they say when they started, they would just do stapedectomies every week, and then 2-3 stapedectomies a week. Now we do maybe a couple or a few a month, so it's just much less frequent than before. But this has been documented. There's actually a nice chart that shows as the MMR rates go up, otosclerosis rates come down, but still nothing you can do about it, meaning I think it's probably related to a genetic susceptibility that probably has some maybe cross-reactivity with antigens on the measles virus, kind of like with COVID and other things that happen with hyposmia and lung issues long term. So otosclerosis can run in the families. It's an autosomal dominant kind of an inheritance with 40% penetrance, meaning not everyone will get it, but there are families that you'll probably see that everybody has a dad, children, and then their grandchildren. It is usually thought to be accelerated by pregnancy or menopause. So oftentimes if you see someone with a conductive hearing loss, they say, oh yeah, I just had a baby last year, and then as I was pregnant, I started to feel like my hearing was getting worse. Then that's a kind of a high suspicious case that this is indeed an otosclerosis case. And usually it begins in the region anterior to the oval window, Sometimes it can be at the posterior aspect. When it's in the front, we call it fistula antefenestrum area or fenestral otosclerosis, but it can sometimes spread and involve the entire otic capsule. What happens is that you get increased osteoblastic and osteoclastic activity, and this results in bony remodeling around the stapes, and you get the first phase that is called spongiosis or otospongiosis. And this is sometimes patients during the phase, they might experience pain and discomfort in the ear, and if you actually catch them during this phase and you look at their eardrum, you might see kind of a reddish or pinkish hue right where the oval window would be. And this is called the Schwarzschild sign. And again, it's another indication that this patient has otosclerosis. But during otospongiosis phase, the conductive hearing loss, if it is present, it's not going to be very significant, meaning if you do a tuning fork exam, most likely they're still hearing better with air conduction than bone conduction. And if we see them, we say, hey, it looks like this is otosclerosis, but you're still not a surgical candidate. We usually want to see a much wider air-bone gap, and we pretty much always do a tuning fork exam in office to determine candidacy for surgery, and we want them to flip both 512 and 1024 tuning forks. We do air conduction, bone conduction, and we want to see bone conduction being better with both, and you also want to see that the tuning fork lateralizes to the same side. In terms of the audiogram, typically you would see a conductive pattern. Early in the disease, you can still have acoustic reflexes, again, especially during the otospongiosis phase, but late in the disease, when the bone is completely fixated, the acoustic reflex will be absent. Now, as you all know, acoustic reflexes can be absent also in moderate to severe sensorineural hearing loss or other conditions. So it is more of a rule out type of a finding, meaning if I see somebody with a conductive hearing loss, let's say this exact audiogram that looks like a pretty wide air-bone gap, but they still have acoustic reflexes, then we doubt the diagnosis of otosclerosis. But if it is absent, I mean, it can still be something else, but that's more likely to be otosclerosis. So one example would be what is called the superior semicircular canal dehiscence syndrome. They can, in advanced cases, they can actually have an air-bone gap, and they would have present acoustic reflexes because the stape is still moving. The problem is somewhere else. And you would also see the typical Carhart's notch that is around 2000, and you would see kind of increase in the bone thresholds around that area. So this is not a life-threatening condition. A lot of people, they've had it for years, and they can actually just continue to live with that, especially if it's one-sided. And then you have the option of fitting them with a hearing aid. I always tell them no risks involved. You can wear a hearing aid, kind of like people with, visual issues like myself. You can choose to wear glasses. Sometimes you have the option of LASIK, and then it's completely optional. Usually younger patients, they tend to choose surgery. Older patients, especially if they're diagnosed around like age 65, they may want to just go with hearing aid, but obviously you can see, either younger or older patients going with either route. It's kind of a personal preference. And with surgery, it is actually one of the surgeries that actually has the highest success rate in what we do in terms of restoring hearing. Like if you have, let's say, if you have, let's say, a cholesteatoma patient that has eroded incus and stapes, you do an ossicular chain reconstruction with TORP. I mean, how often do you see the air-bone gap to completely close, right? But with stapedectomy, the majority of patients will actually have complete closure of the air-bone gap. So should they choose it, there's a high success rate, but obviously there's also risks involved. People could lose hearing as a result of stapedectomy, especially back in the day that people were doing like a full stapedectomy. They would remove the whole foot plate and they put like a precondylar graft. It was much higher. These days we do laser stapedotomy for the most part. We use laser, we crack the crura of the stapes, and then we use a micro drill and drill a tiny hole and then put the prosthesis in there, and then we give him steroids. And so with the modern kind of care, the rate of complete loss of hearing has gone down, but it is still kind of quoted at about 1% that it can happen. So as I mentioned, you can have other ossicular problems. You can have ossicular fixations. You can have erosion of the other ossicles. Some of these are congenital. In certain syndromic patients, especially like pediatric patients, and Dr. Peng, who's another associate from our clinic, will be talking more and touching upon these further tomorrow in his talk. But in such as like golden horse syndrome, you would, for example, see a lot of these issues in ossicular fixations. Sometimes they're secondary to infections. People with chronic ear problems, chronic otitis media, cholesteatoma, that chronic inflammation can result in new ossification and essentially fixation of the malleus head or the anterior ligament of the malleus. Incus is rare, but you can still have fixation of the short process of the incus, and sometimes it's multiple ossicles. So, for example, when we do stapedectomies, I mean, this is pretty rare to find, but as we are examining the ossicles, after we confirm the stapes is fixated and not mobile, we usually pick our Rosen needle and then start checking the other ossicles. It is rare, but I've seen it maybe like once every few years that they also have an incus fixation or they also have a malleus fixation. So as surgeons, when we go into surgery, we have to make sure that's not the case. Tympanosclerosis would be another etiology where the bones can get fixated. So when you look at the eardrum, and I'll talk about tympanosclerosis a little bit further in upcoming slides, but when you look at the tympanic membrane in your otoscopic exam, if you see kind of white patches within the tympanic membrane, even though we call it tympanosclerosis, it is in essence just meringosclerosis. And tympanosclerosis, we like to call it when the same process of calcification actually involves the middle ear. You have those forming in the hypotympanum around the ossicles. That's like a true tympanosclerosis, and that can result in fixation of the ossicles. And in terms of treatment, again, these are non-life-threatening. You don't have to do surgery. Somebody has a malleus fixation with 30, 40 dB airborne gap. They can, easily get fitted with hearing aids and they'll actually do very well, especially if they have intact inner ear hearing and 100% word recognition score. Or we can choose for surgical mobilization or actually removal of the ossicle and placement of a prosthesis. In terms of, I'm sure a lot of you guys have seen like post-tympanoplasty patients. You repeat the audiogram, as I was saying earlier. Unlike stapedectomies, it is very rare to get complete airborne closure. The highest success is when you have erosion, meaning you still have the ossicular chain apparatus that is intact, but let's say the long process of the incus has been eroded. Those have the highest chances of achieving complete airborne closure because you can essentially go in and put bone cement or hydroxyapatite to just bridge that gap. Or if, let's say, just where the incus connects with the stapes, if the bone or the connection or the joint is missing, you can just easily bridge that with bone cement. But let's say your whole incus is gone or fixated and you have to remove it, then you have to put a PORP, or if the stapes is also the problem, the TORP. And again, the airborne gap never closes. I mean, the best you can achieve is probably like 10 or to 20 dB of airborne gap with those patients. So in the right patient, I would say that hearing aid is very reasonable and they would do very well. So otosclerosis can also involve the entire otic capsule. This is called advanced otosclerosis. So oftentimes we see these in patients that have a long history of otosclerosis. Sometimes they've even had stapedectomies. And as they get older, you would expect to see some, worsening of hearing as a result of age-related hearing loss. But sometimes they come to you and it just doesn't make sense. Meaning you look at the hearing test, just one side is way worse than the other. Or let's say you keep checking, like they come to you for their annual hearing aid adjustment, and you look at the audiogram and you see this is kind of dropping faster than you would want to see for just age-related hearing loss. Like last year, their word understanding was 100%. All of a sudden this year it's 80%, and then maybe you repeat it the next year and now it's like 60%. Like, what's going on? So this actually could be a case of advanced otosclerosis, and the same process of bone remodeling will just expand to the entire cochlea, and in really advanced cases, if it's undetected, you will get bony growth into the cochlear duct, and then it can actually cause fibrosis or even ossification of the cochlear cochlear duct. So this is something that, as both ear surgeons and audiologists, we need to be kind of aware of this possibility and actively look for it. And for these patients, you would want to consider early cochlear implantation. And I'm just seeing a patient for this problem, and she has it on both sides. And one side, the word understanding is 32%. The other one is 64%. She had done a stapedectomy like 20 years ago, and then she just came in for worsening hearing. Hearing aids were not helping her, and we got a CT scan, MRI. We found this, and luckily, when we do an MRI, we look for patency of the cochlear duct, and we want to see fluid signal, and that means that they're okay. Now, if you do have a patient with otosclerosis and looks like they might be developing advanced otosclerosis, this is not like hard science, but some people put them on fluoride supplementation or Fluorical, and some of these patients actually can go years without real progression. And that's something that is pretty harmless. Again, not a lot of people believe in it, but in our practice, we do offer it to patients. Some people would do it even with like simple otosclerosis, but that's not very common. But as soon as you see or hear about advanced otosclerosis, that would be something I think, we can all counsel the patients that, hey, you can take fluoride supplementation. There's a chance it might slow down the progress and at least, keep it patent for possible cochlear implantation down the line. All right, so as I was mentioning earlier, you have tympanosclerosis, and comes in two different flavors. The first one is just meringosclerosis, and that is seeing white patches of calcification within the layers of the tympanic membrane. It looks like white plaques. Can be a result of previous otitis media episodes or trauma, such as prior tympanostomy tube placement. If it's just involving the tympanic membrane, usually does not cause hearing loss, or at least much of a hearing loss, and it's pretty benign, doesn't affect the patients or fitting them with hearing aids. However, if we are doing surgery and let's say the part that looks fine has a big perforation, but then the rest of the tympanic membrane is looking like that, oftentimes they may need like a lateral graft, because with medial graft you're dependent more on the body growing blood vessels and for that graft to become one with the rest of the remnant of the tympanic membrane. But if you have something like that, like as we go and kind of try to freshen the rim of the perforation, you don't see any bleeding or any blood vessels coming from those calcified areas, and sometimes you have to remove the whole thing, and then you essentially end up with a near total or total perforation, and then you have to do the lateral graft for them. But just a simple meringosclerosis, really nothing to do if they have a hearing loss. They can easily be fitted with hearing aid. And as I was saying, if the same process advances, and then now they have same calcium deposits around the ossicles and on the promontory in the hypotympanum, then we call it like a true tympanosclerosis. It's the same process as the meringosclerosis, but just involves the whole middle ear. And this could actually fix ossicles and cause a conductive hearing loss. And you can do tympanoplasty and try to remove them. However, it depends. I mean, if you get a CT scan and there's just calcifications everywhere, it would make it very difficult, and I would personally just recommend they get a hearing aid. If they ever, down the line need, let's say, a cochlear implantation, we would remove any plaque that might be in the, like around the round window niche and might obstruct the view of the round window membrane. But otherwise, they will do fine with just hearing aids. And you can bypass that easily. Sometimes you see this if patients have chronic perforations or cholesteatomas, then because cholesteatoma can also sometimes look like that, look like a white patch around the edges of the perforation, then you got to look at the patient's history. If they keep getting infections, if you're suspecting maybe there's some cholesteatoma or ingrowth of skin under that tympanosclerosis plaque, it might be worthwhile then considering surgery. But otherwise, they can easily be fitted with hearing aid. And eustachian tube, even though not exactly in the middle ear, but connects to the middle ear. And a lot of issues we deal with are related to a dysfunction of the eustachian tube. These are more common in childhood and in the pediatric population. And as a specialty of otolaryngology, actually tympanostomy tube placement is the most common procedure we do. So that kind of speaks volumes about how common this is, and I'm sure you guys have all seen it in your practice. And the reason we see it more often in the pediatric population is that the eustachian tube is shorter, slightly wider, and also more horizontal in children. So any pathogens within the nasopharynx, especially if they have like a large adenoid and allergies, it can easily just migrate to the middle ear and cause problems. Eustachian tube reaches its normal size at around age 7, and when we are all children, the angle is about 10 degrees, again kind of more horizontal, but as it matures up, it goes to more of a 45-degree angle. And the length also increases from about the average of 13 millimeters to 35 millimeters. So this also helps with minimizing chances of bacteria or pathogens moving towards the middle ear. The eustachian tube has a protective role, obviously. It regulates the middle ear pressure, it helps with ventilation, and it is supposed to stay closed when we're talking, going about our day. If you need to adjust the ear pressure, sometimes just by the process of talking and chewing, you're pulling the muscles and you're opening it. But otherwise, unless you're changing altitudes, or if you have like a bad cold and your ear is just filled with fluid, you really don't need the eustachian tube to open, so we want it to be closed. So then with the dysfunction, where you have fullness and pressure or fluid buildup, that's when the eustachian tube is just clogged and swollen shut. And you can also have the opposite problem, and sometimes the eustachian tube is just too wide open, and we call that patulous eustachian tube. And believe it or not, that's a more difficult problem to treat. Patients are more annoyed because when you just have a dysfunctional tube, you can put a tympanostomy tube. Now we have the option of dilating the eustachian tube. But if it's a patulous eustachian tube, you can still put an ear tube, but that does not always help them because the autophony can still continue, meaning as they're talking and breathing, air is continuously going into the ear and coming out. So even if you put a tube, it might help with the fullness, but they can still have the sound echoing or autophony. So we think, again, mainly this is related to allergies, and there are some studies that suggest acid reflux as another possibility because it would be irritating to the mucosa of the nasopharynx. And there are some other studies that suggest there are immunological issues. A lot of these kids, they also have immune system problems, and oftentimes if you check their immunoglobulin levels, there will be abnormalities. So if it's not a simple eustachian tube dysfunction, meaning they keep needing tubes or they have severe allergies, we often refer them to allergy and immunology for further workup. Now, when someone has an untreated eustachian tube dysfunction, what happens is that you lose that ventilation of the middle ear, and the air you normally have inside the middle ear gets slowly absorbed, and then you end up with a retracted tympanic membrane, and sometimes it can result in a complete collapse of the tympanic membrane. And sometimes it looks like a huge total perforation, but when we look closely with a microscope, we actually see the epithelium growing inwards, and it's just like stuck to all of the structures on the inside. And another name for it is just middle ear atelectasis. And these are patients that are difficult to treat in the sense that oftentimes they won't have as much ear fullness and pressure as someone who just has a simple eustachian tube dysfunction. But like, for example, you can oftentimes put a tympanostomy tube. When I see an eardrum like this, I always ask the patients to see if they can just auto-insufflate their ears. We ask them to do what is called nasal valsalva. Fancy way to say you just take a deep breath, pinch your nose close, and you pop it. If I see any movement that's potentially promising, then they can actually slowly auto-insufflate and then try to separate the eardrum. If there's a space, we can then go and put a tube, but at least like 80% of the times they try and nothing happens, or even if they try, you see just a little pocket in the front opening up and the rest of it is just stuck. Now it's just adherent, and then you don't have the option. If they're still having issues, you can then just dilate the eustachian tube, but that's it. And then you can also have middle ear effusion. Usually with serous otitis media, if it's bilateral, patient has a long history of eustachian tube dysfunction. If it's looking kind of a yellowish color, pretty classic for just simple serous otitis media. I mean, you guys would refer them to us. We would start them on treatment. We do topical nasal steroid sprays or sometimes oral steroids to control the allergies, have them do nasal valsalva. But if you see a serous otitis media that it's a clear looking like watery fluid, it's just on one side, patient may have certain risk factors, and we'll talk about that a little bit later, but they are able to autoinsufflate, and you see air bubbles, and it just doesn't make sense. This patient has never had any problems. This didn't happen after like an allergy flare-up or infection. Just be on the lookout for what is called CSF leak or cerebrospinal fluid leak, because not infrequently we do see this, and actually people come to us from general ENTs that they saw somebody and then so yeah, it's a serous otitis media, let's go and put a tube, and the drainage never stops. And that's kind of the key differentiating factor, is that the drainage that never stops and looks like clear water. That's highly suspicious for a CSF leak. I'm yet to see one with both eustachian tube dysfunction and CSF leak, but I always check. But again, someone who's had eustachian tube problems, they have had tubes in the past, it's bilateral maybe, or they can't pop the ears and looks yellow. Pretty much that's just a simple effusion, and they would be easily treated with tube placement or addressing the eustachian tube dysfunction. An eardrum like this, sometimes patients come to us, and as long as they are not suffering from just ear pressure fullness, the only complaint is just, I just want to hear better. Like, get a hearing aid, you'll be fine. I mean, we need to still monitor it to make sure a cholesteatoma doesn't form from that retraction and ingrowth of tympanic membrane epithelium. But other than that, if they're really asymptomatic, or let's say they've had multiple tubes, it always falls out, they're always going to end up in square one. As long as they're not suffering, there's no pain, pressure, infection, it's just a matter of just addressing the conductive hearing loss, I would say they would do well with hearing aid fitting. Yes?
Oh, yeah. We do see a lot of people with eustachian tube dysfunction, and they will go on the nasal steroids and the nasal steroids that don't help, over time, and they've tried something different or allergies, and some of them will have tubes. But is there another way to go through the sinus cavity and open that up?
Yes, eustachian, I believe it's coming up, yes.
Oh, sorry, okay.
So eustachian tube dilation was FDA approved for adults, if I'm not mistaken, in 2018. And I believe last year it was approved for pediatric patients. I still haven't done one for pediatric patients because by the time they reach age, when the FDA approval or the age limit is, they pretty much outgrow eustachian tube dysfunction, or they already have tubes that they just never fell out, and then, it's a kid, you don't want to take him to OR for no reason. But yes, you can do eustachian tube dilation, and I'll touch upon that shortly, yeah. Mm-hmm. All right, so as you guys all know, tympanogram would be one of the key factors in evaluating eustachian tube dysfunction. In just a mild dysfunction, you would sometimes just see a type A, and that's kind of a dilemma. We always see these mild cases that it kind of sounds like eustachian tube dysfunction, but everything looks great. The hearing test is great, the tympanogram is type A. Then we, at least I personally look at how well they can just pop their ears, because you look in under the microscope, and sometimes before the patient even trying, you see the eardrums just moving, and then okay, this is not that. But sometimes they have to push real hard, and you see that it just slowly opens up, then you know that this eustachian tube dysfunction is mild or subclinical. So even though they're ventilating, but it's just severe enough that it's causing symptoms. And in more advanced cases, you would see a type C tympanogram, and if there is an effusion, obviously you would see a type B tympanogram. So in terms of treatment, when I see someone fresh diagnosis, or maybe they had an issue before and then just kind of came back, I would start with medical treatment. We tell them to do daily nasal valsalva maneuvers. We do topical steroid sprays, or you can also just observe it if they're really not having much of symptoms. And let's say they just had a flight and they during the descent the ear just plugged up, and they say, it's just my hearing a little. There's nothing wrong with just observing that. But obviously these days, most patients walking out, they would want a medication. So you would would still treat it with topical steroid sprays. And then if that doesn't work, then we get into myringotomy and tube placement. It's been around for decades, and it works. I always tell people, if you want immediate relief, this is the fastest route. And it's simple, it's done in the office, it's quick, but it's not without risks. And often I actually hear from patients having had this done at other places when they come to me and I actually tell them about the risks, and they say, oh, nobody ever told me that I could end up with a perforation, or nobody ever told me that I could end up getting infections. So I always try to counsel them, this is quick, this is fast, this works, but now you have a hole in your eardrum. Some people don't recommend covering the ears. I usually tell them that, if you are going to shower or swim in a swimming pool, just logically you would want to cover that, because if water gets in there, you can easily get to the inside through the eustachian tube. So cover the ear, cotton ball Vaseline works, silicone earplugs work, but I pretty much tell them don't put your head underwater. Do not submerge your head underwater while you have the tube. So some of these patients are swimmers, or they like water activities, or they've had tubes and they fail and they want to do something else, or they just don't want to deal with a perforated eardrum, then the option of eustachian tube dilation comes in. And some people do this in the office. Most people, including our practice, we do it under anesthesia in the OR. And the reason is, if you've ever seen the dilation balloons, it's pretty large, and then you have to put a suction and an endoscope, and then not everybody has a large nasal cavity. A lot of people have tiny noses, so it can be painful. Then you can lacerate the inferior turbinate, or sometimes as you're passing instruments, you can cause a bleeding, and then it's just very difficult to treat that in the office or make it painless. To make it painless, you have to use these long needles that need to go all the way to the back of the nose, and you have to inject them multiple times. So in my mind, it's just easier to just put the patient under, just get it done. They wake up. It's a quick procedure, in and out, probably 15 minutes of anesthesia. And if it works, I tell patients hey, if this works, then you potentially save yourself from needing tubes and worrying about water exposure and infections. But the downside is that it does not always work. The companies, they claim a 90-95% success rate. Personal experience myself, talking to others, and a lot of clinical studies that came from independent groups, it works about 70% of the time. So there is that kind of a balance of pros and cons. You have this option that there's cost involved, anesthesia involved. It may not work, but then if it does work, then you don't need tubes. On the other hand, you have the tube option. It's quick, fast in the office, but you can have perforation or infection. So probably patients are 50-50, depending on what their preferences are. They would go either route. Dilation is usually done once, meaning if it doesn't work, we usually don't dilate it again. And the way it works is people have done animal studies, and they kind of done post-mortem analysis of the eustachian tube. It actually causes cracks in the cartilaginous portion of the eustachian tube. That is the kind of the medial or inner half of it, and that can result in kind of a dilation. Of those patients who fail, usually these are patients that have severe allergies. So if just logically, if you think about it, somebody has pretty bad allergies, everything's just congested, swollen, you go in and dilate it. Even if the cartilage gets wider, just the soft tissue is going to swell up and close it again. So for something like this, I personally at least would want them to have their allergies well controlled. Then you have acute otitis media, and this is something that is very common. Usually, probably they don't make it to you guys in terms of actually, I don't know how many people here work fit hearing aids and how many are just, but I'm sure some in the audience are. These people probably don't make it here. If they do, you most likely will tell them, hey, you have an infection, you have pain, eardrum looks kind of like that, swollen, red. Go see the doctor, come back. But at least they would show up for sometimes diagnostic audiology, and they would have fever, ear pain, irritability, and then you would see signs of inflammation, redness, swelling, bulging of the tympanic membrane, and obviously we would treat this with antibiotics. As the name indicates, it's acute. It should get better with time. Then you have serous otitis media. We kind of touched upon that a little bit, and usually you would see an effusion, oftentimes yellow, sometimes clear, and oftentimes it's painless, or they might feel some fullness or plugged hearing, and then this would be something that, as we talk, can be addressed with different routes. And it is important to examine the eardrum. We cannot always tell what's going on, but oftentimes you would see clues. Like on the top left, picture A is just a normal tympanic membrane. B shows just a mild bulge of the tympanic membrane. This could be fluid, could be just a eustachian dysfunction with maybe they tried to pop their ears and then the air is trapped. And then as you kind of move towards the right and the bottom, then you get into like the actual otitis media. If it has been present longer than 3 months, then we usually call it chronic otitis media. In terms of management, again, observation and effusion is reasonable, but if it's an infectious process, they would need antibiotics, decongestants, antihistamines, topical steroids or oral steroids, and then the option of laryngotomy and tympanostomy tube placement. If it's a pediatric patient, especially with recurrent infections or adenotonsillar problems, then also doing tonsillectomy can help. Cholesteatoma is also very common. I'm sure you guys have encountered that in your practice. The name cholesteatoma is actually a misnomer because I guess back in the day they thought these are coming from cysts that they contain cholesterol, but now we know that this is not true. So a better or more accurate name would be keratoma or epithelial cyst, but nobody uses that. But when patients come to me, they always think, oh, I have a tumor in my ear. And so it kind of behaves like a tumor, but it's actually not a tumor, meaning in certain cases when we do a canal wall down mastectomy and create a cavity, you actually can use the matrix of the cholesteatoma as a normal epithelial coverage or skin. So it's not tumorous, it's not cancerous, but it can behave like one, meaning as you accumulate the keratin debris, it can grow and cause infections, and that will obviously be problematic. It usually develops from retractions of the pars flaccida, so oftentimes when you look with the otoscope, you will see a little bit of a retraction pocket. If you see the depth of it, then that's just a retraction pocket, but if you don't see the depth, by definition, that is a cholesteatoma. And I would oftentimes just get a CT scan because I don't know, is it going deeper than what I can see, like just a millimeter, or is it going into the entire mastoid, or is it going into the brain? So we would get a CT scan. There are different types of cholesteatoma. You have the primary acquired, which is usually in the setting of eustachian tube dysfunction, or kids who've had multiple ear problems, ear infections. You get retraction pocket from the pars flaccida that can sometimes grow inferiorly towards just the middle ear space, or sometimes it can grow towards the mastoid. And there are different theories in terms of what happens here. Some people say it's just a retraction. Some people think that it's actually metaplasia of the epithelial tissue and actually starts invading the tissues. And we see this actually more with canal cholesteatomas, with that we still don't understand why they happen. And sometimes you can have a pars tensor retraction pocket, but this is less common than the superior aspect of the eardrum. Then you can have secondary or acquired cholesteatomas. This usually happens in people with pre-existing perforation, and we think the reason is, as let's say somebody gets an acute perforation, like what happens when those 50-60% of the times that they heal spontaneously? The layers of the eardrum grow and they kind of meet somewhere in the middle, and then they kind of fuse and they heal the eardrum. But as if they're growing, if it's a big perforation and they don't reach, sometimes they kind of start falling in. They start growing inwards, and you get cholesteatoma growing from a perforation. So oftentimes when we do tympanoplasty, as we lift the eardrum up, we look at the undersurface and make sure there's no skin underneath it. And sometimes a hole that's just 10% of the tympanic membrane, after you remove all the secondary cholesteatoma, ends up being 70%. So that's something, I guess, for us to be aware of, but it's also good to know that a perforation can also have a cholesteatoma. You have congenital cholesteatomas, and they're actually it's a completely different disease than adult cholesteatoma. These form from embryonic epithelial tissues that get kind of stuck inside the temporal bone as fetus is developing. And usually when you look with an audiogram, you would see a white pearly mass behind the tympanic membrane. And this is actually in the anterior superior aspect of the eardrum. And oftentimes it's asymptomatic. So again, pediatric patient, white pearly mass anteriorly, maybe no hearing loss or no really significant history of ear problems, suspect a congenital cholesteatoma. We would still operate on it, but something like this, if the kid is really young, I mean, no reason to put them under anesthesia at this in my mind. I think you just need to follow them along, or if they come to you for, let's say, hearing aid evaluation, just keep an eye on it. If it's growing or starting to look weird or causes problems, then they need to come see us and then have that evaluated and potentially removed with surgery. So cholesteatomas, they cause inflammation, infection. They can cause granulation, polyps. There will be crusting or cerumen kind of coming out of the pars flaccida. You should not have cerumen coming out of the eardrum. Sometimes people use Q-tips. Yes, they push the wax deep. But if you look at the eardrum and the ear canal's clear, and the only thing you see is just some debris or cerumen coming from the superior aspect of the tympanic membrane, suspect a cholesteatoma. Oftentimes, if we do an evaluation and CT scan, you see that there is a retraction pocket coming from that area. They can have a progressive conductive hearing loss as the cholesteatoma grows. It can erode the ossicles, or it can just kind of abut the tympanic membrane and dampen the vibrations, and can result in conductive hearing loss. If it starts invading the audit capsule, it grows into the inner ear or causes fistula of the horizontal canal, or rarely, if it's really advanced like posterior and superior canal, then it would actually result in dizziness, vertigo, and sensorineural hearing loss. So again, any cholesteatoma patient, you hear about these symptoms, always suspect that, and obviously if they are referred to us, we would be evaluating them with CT scan and MRI. So the treatment is oftentimes surgery. We can do simple surgical removal and tympanoplasty to repair it for small cholesteatomas, or if it's really advanced or they've had erosion of the canal wall, then we would do either exteriorization or canal wall down mastoidectomy. Oftentimes, we counsel the patients that depending on how big the cholesteatoma is, where it's growing, because certain areas inside the ear or inside the middle ear are more notorious to hide a cholesteatoma, like sinus tympani or facial recess or hypotympanum or supratubular recess. These are those little hole, like air cells and creases around the ossicles and behind the facial nerve, and they can actually go hide in there. So if it's a cholesteatoma that extends to these areas, then often they may need a second look procedure. Essentially, with the first surgery, you remove the disease, you reconstruct the eardrum, and we would place a sheet of thick silicone to maintain the middle ear space, because oftentimes they don't have good ventilation. If you just go in and reconstruct it, like next thing you see, like 6 months later, the entire eardrum has collapsed, and then you can develop another cholesteatoma. So if you guys ever send the patient to us with cholesteatoma, we operate on it. If they need a second look, we always counsel them, hey, just wait on your hearing aid. Let's just do your second surgery, and we'll do a reconstruction, usually at the second surgery. And then once that has kind of healed, then you can go back for your hearing aid fitting and evaluation, because as I mentioned, oftentimes if you do like a canal wall down mastoidectomy, hearing is not going to be normal. And even if you do an ossicular chain reconstruction, oftentimes they're still going to have an airborne gap. So if someone comes to you and, right, there's those of you who do hearing aid fitting and they say, oh yeah, I'm supposed to go back for surgery. I mean, they can still get a hearing aid if we know they're going to need it anyway, but just one caveat that they may need to come back for an adjustment, and potentially, I mean, if it ends up being a canal wall down, then hearing aid fitting could be a problem, and we'll kind of touch upon that a little bit later. But yeah, some of these will need that second look procedure. All right, another condition to be aware of is a benign tumor called glomus tympanicum. So this is a small benign vascular tumor, and it can actually be much larger. Then it would be called glomus jugulare, which would involve the jugular bulb that is kind of at the inferior aspect of the middle ear where the hypotympanum is. And glomus is also another misnomer. The better term to call these is a paraganglioma, and they arise from paraganglion cells that they kind of run along the Jacobson's and Arnold's nerve in the middle middle ear, and they get their primary blood supply from the ascending pharyngeal artery. So if it's a really big tumor and they come to us for surgery, we might actually embolize these tumors before surgery to just minimize risk of bleeding. But if it's just a true glomus tympanicum, which by definition would be limited to the middle ear and maybe slightly extending to the mastoid, oftentimes we would just do surgery. Now, some of these patients are really old. Let's say a 92-year-old that was just diagnosed and they're poor candidates for surgery. We know these are benign and they grow very slowly, and the only issue they have is just hearing loss. I mean, it's very reasonable to also just fit them with hearing aid as long as a surgeon is kind of keeping an eye on it and make sure it's not really rapidly enlarging. Symptoms would be ear fullness, hearing loss, and oftentimes pulsatil tinnitus. If you look with the otoscope and you see the eardrum kind of looks like that, it looks red and there's something behind it. If you have a microscope, I mean better, but if you have an otoscope that you can change the focus or magnification, sometimes you actually would see the mass pulsate through the eardrum, and then you know this is a glomus tumor. And then one thing to also, I guess you could also do is if you use a pneumatic otoscope and you seal the eardrum, as you look in there, you could try to push the bulb. You sometimes see what is called the Brown sign, meaning that air pressure from your pneumatic otoscope can actually cause a little bit of a blanching of the tumor. That's another thing that can help you distinguish, for example, a tumor like this from just simple hemotympanum. It is hard to see it. I'm actually yet to see it, but in the office. But I've seen like videos online that you actually clearly can do that. But with otoscopes, especially in the office setting, like as ear doctors, I mean, sometimes you don't find the exact ear speculum that would seal the eardrum to be able to do that. But anyways, when you see it, it's like really cool. In terms of workup, we would get a CT scan and MRI to A, confirm the diagnosis, and then B, see how extensive this is. Is this just a glomus tympanicum, or is this also a glomus jugulare? And treatment could be surgery for smaller tumors. For bigger tumors, you can still do surgery, but if it's a true, let's say, glomus jugulare, where it goes and wraps around the jugular bulb, I mean, that can become very complex, and especially if it's on the dominant side, because the jugular bulbs that drain the brain's blood towards the heart, we usually have a dominant side, and it's usually on the right side. So if you have a big tumor around that, pretty much you can't do surgery on it because of risk of stroke. So what most people end up doing, if their only problem or their main complaint oftentimes is just pulsation in their ear or hearing loss, we would resect the middle ear portion and either observe the rest of it or do stereotactic radiation. It doesn't kill the tumor, it will stop the growth of the tumor. So that might actually be all a patient needs, because at the end of the day, again, these are benign, and if they have a residual hearing loss, they can easily be fitted with a hearing aid. Next is myoclonus. This is oftentimes described by patients as kind of a constant clicking or crackling in the ears. Now, Eustachian tube patients sometimes have that too, so then you have to talk about the history. Okay, do you have any ear pressure, history of ear problems, infections, allergies? But if it's a healthy person, all of a sudden they start hearing clicking in the ear, then this is something that we should suspect. And it is, in essence, a sudden involuntary muscle spasm or twitches. We get them around the eyes, in your arm, legs, and then these are just, spasms of the middle ear muscles. You have tensor tympani, and then you have the stapedius muscle, and just like any other muscle in the body, they can start spasming. Usually we would see this in patients who are really stressed, migraine patients, or patients with musculoskeletal disorders. And then in terms of working them up, we would examine them. If you look at their palate, if it's a palatal myoclonus, you would actually see spasms of the palate. So oftentimes I just have them like open their mouth, use an otoscope, just shine the light, look at the palate, and I tell them, why don't you tap on your lap as you hear the clicking, and then you see every time they tap, the palate is also going up, then you know it's the palatal myoclonus. If it's a middle ear, usually you don't see it, then it doesn't matter as much in terms of how you treat it, but in terms of just for like curiosity or diagnosis, we always ask them, okay, how fast is this clicking? Is it like a flutter, like, or is it like tap, 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 and then stops and tap, tap like that? If it's a flutter, the consensus is that it could be a stapedius myoclonus, otherwise it's a tensor tympani. But regardless, I mean, exam is usually normal. I mean, sometimes you might be able to see the tympanic membrane movements as you look with the otoscope, or during your tympanogram, you might see kind of little abnormalities there, but oftentimes everything comes back as normal. In certain cases, if it's persistent or if it's recurrent, we might get an MRI because, I mean, these muscles are innervated by nerves. And what if this is a tumor of the facial nerve or tumor of the trigeminal nerve? So again, this is not very common. So most of these patients, it goes away. But I would say if you get a patient like this, that it's been 6 months, a year, that just the clicking never stops, even if they're fine with it, I would at least recommend getting an MRI so you make sure that, okay, there is nothing serious going on here. Treatment-wise, reassurance, oftentimes once the stressor goes away, this goes away as well. You can give them like calcium, vitamin D, magnesium supplements. It can help sometimes. Use of muscle relaxants can help. And in really severe cases, you can essentially do surgery. You can just do a tympanoplasty and just cut the muscles. This is not something that's done commonly. I didn't see this done in my residency, fellowship, and since I've been practicing, meaning most of these patients, it either goes away or they respond to muscle relaxants. But this option does exist if you ever have a patient that just tried everything and nothing's working. It would be actually a transcanal procedure, kind of like a stapedectomy. We just cut the ear canal, lift up the eardrum, and then we might need to do a little curetting to expose the muscles, and then we either use laser or scissors to cut the muscles, and that would essentially fix the problem for the patient. Temporal bone fractures, again, not exactly like a middle ear pathology, but it can oftentimes involve the middle ear. They are relatively uncommon of all the fractures that you would see. And of all the head trauma cases, maybe 3 or 4% of them may have a temporal bone fracture. And it predominantly affects males, probably just because the profile of, high risk activities. Usually if you do see a patient with a temporal bone fracture, or if they tell you if they've had a temporal bone fracture, it usually indicates a severe trauma. So if you get any sense that the patient hasn't been properly worked up, they need to go get a full evaluation. You don't just get a temporal bone fracture, or the capsule is pretty robust. So this must be like a really severe accident. Like usually we see it with patients who fall from a ladder, like backwards, from usually like a third story, second story, something like that, like a really severe case of trauma. And then patients can have ear bleeding, they can have hearing loss, tinnitus, vertigo, they can have facial paralysis in certain cases. Exam usually would have like external auditory canal laceration, bleeding. They can have hemotympanum, which is just blood accumulating behind the tympanic membrane. You would see kind of a reddish, purplish or pinkish hue. And then sometimes they can have CSF leak, and that would be the clear fluid. And sometimes they can have a ruptured eardrum if it's a really severe case of trauma. They will all need a CT scan to evaluate the fracture line and associated injuries. Historically, fractures have been classified into longitudinal versus transverse. These days, we usually just use the classification of otic capsule involving or otic capsule sparing fracture. It means if it goes through the otic capsule, then they're going to have hearing loss, they're going to have vertigo, and then they might actually end up with calcifications within the cochlear duct, and they would be, especially if it's like a complete case of a complete loss of hearing, they may need early CI or cochlear implant intervention. They will all need an audiogram. We often recommend waiting about 6 weeks at least, because let's say they come to you like within 3 days, and that actually does happen. I've seen it because obviously patients very scared, their hearing is affected, they had a fracture, they told them, hey, your ear bone is broken. They want to go and get a hearing test, and that's fine. You can do a hearing test, but I mean, if you see a conductive hearing loss, is it truly a real conductive hearing loss, or is it just from all the blood sitting in the ear? So if they don't hear anything at all, then that's potentially like let's say, sudden hearing loss or complete loss of hearing, then yes, by all means, do the audiogram, refer them to us or someone to give them steroids and do the full evaluation. But if it's just a conductive loss, or if they don't, like, let's say they have like better bone conduction than air conduction, then we know it's probably either a true conductive hearing loss or just from the blood. And usually we would want to wait 6 weeks to get kind of the full picture, because by then all the blood is absorbed, and then if you still have a conductive hearing loss, that means that is real and needs to be worked on. So with kind of longitudinal fractures, you would see this more often. They can have the conductive hearing loss would be seen more often. They would have a rupture of the eardrum. If there's any effusion, it should raise the suspicion for CSF leak. And oftentimes this is due to discontinuity of the ossicular chain. And the most commonly involved location is the incudostapedial joint. It can easily separate or dislocate. And then ossicular fracture is the second most common, as usually is the crura of the stapes, which is the weakest point. And in terms of treatment, if it's just a little bit of a conductive loss, we would recommend that if they want, they get hearing aid fitting. If it is a huge gap, or let's say you do a CT scan, you see a clear problem that you can maybe help with. Let's say if the joint is separated, you can try to put a bone cement, then surgery, I think, would also be reasonable. But as long as their main issues have been addressed, surgery is honestly just optional. They would do very well with hearing aid fitting. Sensorineural hearing loss would indicate an otic capsule involvement. As you can see here, I'm not sure if you guys can see my pointer. There is a fracture line that's kind of going here through the vestibule, and same on this side, it's going through the cochlea. So with these fractures, you have the risk of ossification, and especially if they've lost hearing completely. A bilateral case like this, I've only seen it once when I was in residency training. A guy, typical case, fell from a ladder, bilateral otic capsule involving fractures, profound loss, didn't come back after like 2-3 months. And these would be at risk of getting calcification, so we would start them actually for CI evaluation for bilateral implantation at the same time, because if you get that ossification, they lose that window of opportunity for implantation. And these patients are also at risk of getting meningitis, especially if it's a ruptured eardrum. They need to be put on antibiotics and eardrops, because if they develop an ear infection and there's a fracture line involving the skull base, they can easily end up with a meningitis through the CSF leak. Next, encephalocele, not uncommonly, we actually do see it, and sometimes patients' only symptom is just the conductive hearing loss. And if the encephalocele, which is herniation of the brain tissue inferiorly towards the middle ear, abuts the head of the malleus or touches the malleus and incus, they would easily just present with a conductive hearing loss, and they might actually be without a CSF leak. There might be no effusion. A CT scan would be able to pick this up. If it's just a tegment mastoideum, you don't need to do anything about it. It's not even going to cause a hearing loss. But if it is tegment tympani and abutting the ossicles, you still don't have to do surgery, especially if they haven't had CSF leak. But that would be a cause for conductive hearing loss, and surgery can potentially fix that for the patient. In terms of why this happens, people think some of these patients have congenital defects. Some of them is a result of trauma, such as a temporal bone fracture. Sometimes infections can do this, or let's say cholesteatomas. If they grow superiorly, they can thin the tegment. Eventually, if it's a patient with, let's say, intracranial hypertension, they can get herniation of the brain through that weak spot. And some of these patients have had previous surgeries. Somebody drilled the tegment, maybe trying to identify something or trying to fix something else. And again, down the line, they can end up with this. And again, a lot of these patients will be a little bit on the obese side or severe obesity, and then they will have obstructive sleep apnea or intracranial hypertension. So these are kind of risk factors that when we see, we kind of have a higher kind of alertness that, okay, what if this patient has this condition? So symptoms may vary, but usually, again, if it's touching the ossicles, they would have a conductive hearing loss. They would get tinnitus, ear fullness. If there is associated CSF leak, they would have a clear effusion in the middle ear. And if you put a P tube, then you can get just persistent otorrhea through that, and it would be a clear, watery fluid. And if they get recurrent infections or meningitis, then you really need to operate on these patients. Although sometimes once every few years, I do get a patient that they just don't want to do surgery, and then I tell them, hey, you're risking infections. As soon as you feel any ear pain, fever, you got to call us, or you got to tell somebody to treat you with antibiotics to prevent an infection. In terms of diagnosis, they would need CT scan and MRI. If there is middle ear effusion, we can aspirate it and send that for a protein called beta-2 transferrin. It can be found in certain fluids in the body, but when it's in the ear, the only explanation is essentially a CSF leak. And once you get that, then there's no question that this is a CSF leak patient. And then you would need to do surgery to repair it. And if they have risk factors such as obstructive sleep apnea or intracranial hypertension, we would have them either see a sleep medicine doctor or a neurologist to have those addressed. In terms of surgery, there are different approaches. There's transmastoid that's just done through a mastoidectomy approach. It's you essentially try to fix it from below. There is middle fossa approach that you would kind of open a window into the skull from above and try to fix it. But oftentimes we end up doing a combined approach going from both directions, because if you just go from above and you have an encephalocele that's touching the ossicles, sometimes trying to pull it out from above, you can end up actually dislocating or pulling the ossicles, and that can actually be very traumatic. Not only can cause conductive hearing loss, if it is a really traumatic force, it can result in a sensorineural hearing loss as well. So what happens is that we usually end up doing a combined approach, and then we would resect the encephalocele tissue. Believe it or not, it's dead brain tissue. It pretty much never does any function, and removing it, if you can push it up, that's fine, but oftentimes it's like wrapped around the ossicles, and we just end up kind of resetting it at the skull base. And then it would be a joint surgery with us and a neurosurgeon, and we would put tissues and try to fix the dura and also fix the skull base. We're going to get a little bit into kind of a more uncommon conditions that, again, that these are things that one might see like once every 10 years or so, but especially if you're seeing pediatric patients, it's good to always be alert and aware of these problems. Osteogenesis imperfecta, it is a hereditary disorder of the connective tissues, and this makes patients susceptible to develop pathologic fractures. Usually it is autosomal dominant in terms of its inheritance pattern, and it can vary in terms of severity, and usually involves production of the collagen, and collagens, it could be types 1 and also all the way through to type 4. And in terms of their otologic symptoms, they can develop a conductive hearing loss, and they can also develop a sensorineural hearing loss, and it is present in 90% of these individuals. So if somebody has this, there's a good chance they will end up seeing an audiologist at some point. If there is conductive hearing loss, it is usually due to either pathologic fracture of the ossicles or fixation of the stapes footplate. And the phenotype that actually develops conductive hearing loss, they are also more likely to have this kind of a unique blue sclera. So if you see a patient walking to your office and the eyes are looking kind of blue, or the white portion of the eyes looking blue, and they have a conductive hearing loss, and if they're a kid, maybe their bones are maybe looking a little weird, or they have like a cast over their arm. Suspect this condition. And this is essentially treated just like any other condition. You can fit them with hearing aids, and if it is just a stapes fixation, then you can consider stapedectomy, or in terms of other ossicle involvement, you can consider surgery. Another kind of a similar condition is osteopetrosis. This one is a little bit more severe, and usually it's a disorder that causes faulty bone remodeling, and it is also autosomal dominant, but can also be autosomal recessive. And I guess I should also clarify, I guess you guys know, but autosomal inheritance, it means that you pass it with non-sex chromosomes, so 1 through 22, I believe, from medical school days. And then dominant, it means that you can only have just one defective copy and still get it. Recessive, it means you have to get 2 defective copies, one from each parent. These patients would have a progressive enlargement of the head, mandible, and the long bones, and they can develop progressive neuropathies. As the bone's enlarging, it can start pressing on the facial nerve. It can cause pressure on the internal auditory canal. They can end up with hearing loss, imbalance, dizziness, and facial paralysis. And And as surgeons, obviously, we would assess that and then determine if they need any sort of surgical interventions. But in terms of hearing rehabilitation, again, hearing aid would be very reasonable to address their conductive hearing loss. You could consider surgery, but for something like this, probably we know it's going to just get worsened over time. So, I mean, if they really want the surgery, you can certainly do it with a grain of salt, but they would also be fine with just hearing aids. Another condition that actually we do see it not infrequently is Wegener's granulomatosis, or nowadays they call it granulomatosis with polyangiitis. And this is an autoimmune problem. We actually don't know why it happens, but we know that these patients have circulating and depositing immune complexes, and they develop vasculitis and granulomas. It often involves the nasal cavity, so they can have what is called a saddle nose deformity or perforated septum, and they can also have ear involvement. It's not very common, but about a third of the patients will have ear involvement. So you would see sometimes like diffuse swelling of the entire auricle that's maybe not infectious or could be chronic, meaning there's not much pain, but it's just red and swollen. They can have perforation of the tympanic membrane. They can have otitis media, otorrhea. They can get vertigo. They can have hearing loss. Essentially, this is because these immune complexes, they just deposit within the tissues, and then depending on where they are, you would get those symptoms. In terms of diagnosis, we would test the patients for ESR, that checks for inflammation level. C-ANCA is a special antibody we can test, or it's actually a panel that if they test positive, again, would help establish the diagnosis, and usually we would send them back to a rheumatologist or their primary care to be treated with steroids and also immunosuppressants. So in terms of like a kind of a day-to-day practice of an ear doctor and audiologist, if you ever see someone with, let's say, perforated tympanic membrane, clear discharge that kind of looks mucoid, they have a lot of pain, but there's really not an infection, it's not responding, and then maybe you're going to talk to us, or we saw them, and then CT scan, everything's normal, this is not CSF leak, suspect this. I have seen this at least a couple of times in my practice, that the patient ended up having Wegener's, and then you just test them if it's positive. For C-ANCA, you send them to a rheumatologist, they get treated, it actually gets better over time. But if they have any sort of residual hearing loss after disease has been well controlled, then hearing aid fitting is very reasonable. All right, so back to the case that we started with. So I actually didn't mention what this is, and that would be the next topic. So this particular patient ended up having what is called the Hossein high-riding jugular bulb. How many people have seen it or heard about that before? All right, so this is actually, again, not too infrequent. Maybe a few times a year we do see this issue. It's not a tumor. It's not, I guess, life-threatening. What happens is that normally, I guess I can go to the next slide. Let's see the pointer. So if you look at the anatomy of the middle ear, and this is hypotympanum, and this is where the jugular dome is and the jugular bulb is, and then turns into jugular vein and goes down, you would have a bony coverage in this area. But sometimes the jugular bulb has a trajectory upwards, and you might actually even see the dome that's covered with the bone through the tympanic membrane, or when we lift it up during surgery. That is just called a high-riding jugular bulb. Now, if the bone is missing, then you would get this, meaning you essentially have a jugular vein or bulb that's in your middle ear, and sometimes it can be too big and about the eardrum and cause a conductive hearing loss. CT scan would easily diagnose this, and we sometimes would still get an MRI just to make sure this is not like a glomus tumor. And as long as there's no enhancement, then we know that this is the Hossein high-riding jugular bulb. And this is something that is fixed with surgery. These patients would oftentimes have just pulsatil tinnitus. They hear a humming or pulsation in their ears, but if it's really superior and touching the tympanic membrane, it would result in a conductive hearing loss as well. And the principle of treatment treatment is that you want to just cover it. We would use cartilage, fascia, bone graft, cartilage graft, usually multiple layers to cover it, and that usually resolves the problem. Now, this particular case was pretty significant because it was almost coming and touching the malleus. So these are pretty hard to completely push down and control. So they might still have some residual conductive hearing loss, but at least that could help with their pulsatil tinnitus that is annoying. Milder cases, you would be able to actually cover it and sometimes maybe even push it a little bit with like a cartilage graft, and that would help with both hearing loss and with their pulsatil tinnitus. And this patient's kind of a pre and post-op audiogram. They actually did very well after the surgery. All right, with that, I think it's about time. I'm going to conclude the talk, and I'm happy to take any questions. Yes.
What conditions would you use
What conditions would you use intratympanic injections?
Sudden sensory neural hearing loss, for sure, and Meniere's disease. For any episodes of sudden loss or sudden drop in hearing, we would still do it. But even for patients with refractory vertigo that they don't respond to treatment, we would still offer them intratympanic steroid injections. Usually, yeah, these are the two. Or if somebody has had like a trauma, such as like let's say they were involved in a car accident, they didn't get a fracture per se, but it was what is called the labyrinthine concussion, meaning they just lost hearing and we get CTM, everything's fine, but then they still lost hearing, you would still offer them injection. However, in terms of what to offer first, most people would offer them oral steroids first. Steroids are optional. Some people would give them injection at the same time. Some other people would probably wait to see if the oral steroids are working or not. And if somebody cannot get oral steroids at all, let's say they have poorly controlled diabetes, glaucoma, or they've had prior reaction to steroids, we could also just offer them intratympanic steroid injection.
Thank you.
Yes.
What is third window condition for the middle ear condition, and how do you treat it?
Right. Very good question. I was debating whether to include it. So the third window is technically not a middle ear pathology, so that's why I didn't include it in this talk. But it is essentially defined as a third window into the otic capsule. So the otic capsule involves your cochlea and your vestibule and your semicircular canals, and you have perilymph and endolymph and the different chambers that are there. It only has two windows to the outside world. The oval window where the stapes footplate sits, and then you have the round window. And the idea is that the oval window vibrates, and with the round window being in cochlea, it directs the kind of the mechanical motion of kind of the waves through the endolymph towards the round window. So if you have a dehiscent superior semicircular canal, which is defined as thinning of the superior semicircular canal, and the bone is missing and the brain is touching the labyrinth, then what happens is now you have a third window. So when sounds are entering the vestibule through the vibrations of the footplate, instead of going this way, some of it will dissipate and go the other way. So that results in a conductive hearing loss. And because now it's going to the vestibule, it can also cause dizziness, it can cause sound-induced dizziness or pressure-induced dizziness. So most often it is a result of superior semicircular canal dehiscence, but you can also get it with cholesteatomas that erode the lateral canal and they cause a fistula, or sometimes we see it iatrogenic if someone does it in the lymphatic sac decompression, because as a part of it, you're supposed to identify the posterior semicircular canal, and then your lymphatic sac is going to be inferior to the Donaldson line that kind of halves the posterior canal. So if they go too aggressive finding the posterior canal, it can also be caused iatrogenically, meaning you can get fistula of or third window of the posterior canal. But most often you see it with superior semicircular canal.
Thank you.
You mentioned myoclonus and clicking or pulsatile. Like, how do you do a differential diagnosis between that and TMJ, where they also
With the clicking?
with the clicking?
The key question is asking them, is it happening spontaneously when you're doing nothing, or is it with eating and chewing? If they say, yeah, every time I eat or chew, could be palatal myoclonus or could be TMJ. You can ask about like history of TMJ problems, pain, tenderness in this area, history of grinding, clenching. But if there is a true clicking coming from TMJ, if you just palpate and ask the patient to open their jaw and close, you would see it. How often are we eating? Like when you're just watching TV, you wouldn't get clicking from your TMJ. So the key is that, is it spontaneous or is it associated with some other event? Yes.
When a patient has pulsatile tinnitus and they are worked up for that and nothing is found, and it continues for many, many years, doesn't get worse, there's no hearing loss, do they need to be worked up again at some point to see if any of these other things come into play?
So pulsatile tinnitus, I would say at least 90% of the times we do find a reason, meaning we get CT scan. You asked about pulsatile tinnitus, correct? Pulsatile. Yes. We would get, I would get a CT scan, MRI, MRA to look at arteries, and MRV to look at the veins. But even with this, at the end of the day, you only have 95% sensitivity. So it depends on the patient, especially if it's unilateral, then potentially dangerous. So if everything comes back as normal, I tell them, hey, at least we ruled out all the serious things with 95% certainty, but if you really wanted to kind of get to 100%, then we would send them for angiography, either to interventional radiology or a neurosurgeon who does neurointerventional procedures, and then they would do an angio. Essentially, they put them to sleep, they introduce the catheter, go to the vessels of the brain, they infuse a dye, and they kind of record a video as they're doing that. And not infrequently, they actually do find stuff there. I would say if it's mild or if it's intermittent, if it's bilateral, could be just like intracranial hypertension, or could be just someone's stress or their high blood pressure. They have high blood pressure, maybe hyperthyroidism, stuff like that. But any pulsatile tinnitus, at the end of the day, I would not let them go or discharge them, at least until I've ruled out everything I can or offered them the option of doing angiography, because you just don't want to miss like a small aneurysm that was missed.
Do my best to say some of these words. Regrading cholesteatoma and wearing hearing aids, can you speak to how to assess the degree of occlusion or hours of wear that would be healthy?
Say the last part again.
Can you speak to how to assess the degree of occlusion or hours of wear that would be healthy?
Occlusion, I guess, in terms of the hearing aid occlusion, I'm assuming?
Yes, they're regarding wearing hearing aids.
If it's a dry cholesteatoma, small, let's say it's just a little bit of a debris within the flaccid portion, and they really don't have infections, we're monitoring it, I wouldn't restrict them. But if it's an ear that keeps getting infections, certainly wearing hearing aids during the infection, at least I don't recommend it. I usually recommend they keep it open. But if it's an ear that's prone to infections, then sometimes I might ask them to maybe limit the number of hours they wear, or if they can come to their audiologist or hearing aid dispenser and then have them maybe create vents inside the dome of the hearing aid, that might be helpful. But other than these situations, I would say, if it's something that we operated on or we're just monitoring and really not causing problems, they should be able to use it regularly.
Okay. how to differentiate between patulous eustachian tube and eustachian tube dysfunction.
Dysfunction, yeah. It is challenging sometimes, as I'm sure you guys have seen it in your practice. Not everybody fits in, certain boxes. But there are key things to look for, especially, I guess, for us, since we look with a microscope, it's easier. But sometimes, even with an otoscope, you should be able to see it. Is that I always ask them to breathe through. Let's say if I'm assessing the left ear, I will have them just keep their mouth closed, just breathe through the nose, block the right nostril, just take deep breaths through the left nostril. So they would go like in and out, and as you look under the microscope, sometimes you see the eardrum move with breathing. It's not supposed to do that. If I see that, that would establish a patulous eustachian tube dysfunction. One other thing that is simple that you can do is that if they have a lot of autophony or hearing their own voice, we ask them to just bend forward and drop their head below their level of heart. So this way you get a rush of blood to your head, tissues get congested. If they say, oh yeah, I feel a lot better, like my autophony is gone or my ears don't full anymore, that's another indication that this is indeed a patulous eustachian tube dysfunction. Because if it's a true dysfunction with like just the tube being too swollen shut, then it should not get better when they do that. And this is, I'm assuming, you have a normal tympanogram, because if you have a type C or type B tympanogram, then clearly it's a dysfunction, not a patulous one. And sometimes with patulous, you might see a type AD audiogram, but again, that's pretty rare. Did that answer the question?
I'm sorry, I didn't hear you.
So I asked if that answered the question for the gentleman or lady who asked it. Hopefully, I guess we'll know.
Yes, you did.
Okay.
We have a couple more questions online, but we are out of time.
Okay.
So.
All right. Well, thank you so much for having me.
Thank you.